Thanks very much, Francis. Well, it's a pleasure to be joining this just fascinating meeting today. I've been enjoying all of the talks this afternoon. And it's a pleasure to speak with you about our work in the ethics of cluster randomized trials. So what is a cluster randomized trial? Well, unlike individually randomized trials, cluster trials randomize intact social units. Cluster trials are complex and multi-leveled, so that in one study, hospitals may be randomized, health providers intervened upon, and outcome data collected from patients, often by accessing electronic health records. So as the illustration suggests, these are complicated studies. Cluster randomization is an increasingly popular design. And types of cluster randomized trials are various and include parallel arm trials, parallel arm before and after trials, cluster crossover, and step wedge designs. So when would one choose a cluster randomized design? When interventions are delivered to the cluster as a whole, as in a public health intervention, or the health provider, as in a knowledge translation intervention, a cluster randomized design is the only randomized option. However, when the intervention is delivered to an individual patient, both cluster randomized designs and individually randomized designs are possible. So why do cluster trials pose difficult ethical issues? Well, cluster randomized trials raise difficult ethical issues because of their design. They involve groups rather than mere individuals, and the moral status of groups may be unclear. These are complicated studies, and as I've just illustrated, in the same study, hospitals may be randomized, health providers intervened upon, and patient data collected. Further, the intervention may occur at differing levels, including the cluster, the professional, and the individual level. And finally, research ethics guidelines were written with patient randomized trials in mind, and as a result, the application of guidelines to cluster trials is fraught. Fortunately, there is guidance. The Ottawa Statement on the ethical design and conduct of cluster randomized trials is the first international ethical guidance specific to cluster randomized trials. So the Ottawa Statement encompasses 15 recommendations divided into 7 ethical domains, as you see here. And in the remainder of the talk, what I'd like to do is give a brief overview of several of these domains: justifying the cluster randomized design, identifying research participants, obtaining informed consent, and gatekeepers. So let's start with justifying the cluster randomized design. Why does this need to be justified? Well, basically because cluster randomized trials are statistically inefficient. And why are they inefficient? Because the outcomes of individuals in the same cluster are usually positively correlated, and that reduces the effective sample size. So that can be quantified with what's called the design effect, which is a function of cluster size and the intra-cluster correlation coefficient. So if we take a common cluster size of, let's say, 100 people and a common intra-cluster correlation coefficient, say, of 0.05, what we see is that a cluster trial would be 6 times larger than a comparable individually randomized trial. So these are statistically inefficient designs. Furthermore, these designs are more prone to bias. At the cluster level, the fact that fewer clusters are randomized means that there's a greater chance of baseline imbalances. And attrition bias due to a loss of clusters is a major problem. At the patient level, clusters are usually randomized before cluster members are identified or recruited. And as a consequence, if researchers and participants are not blinded, identification and recruitment bias may result. So that's a scientific concern. All those things are scientific concerns. Why are those also simultaneously ethical concerns? Well, the choice of a cluster randomized design requires justification ethically because more patients in a cluster trial are exposed to study burdens and risks. Now, those additional burdens and risks might be justified by appeal to the benefits of the study, but at the same time, bias may undermine the social value of the study, the benefits of the study, a key component of the harm-benefit calculus. So that's why this is an ethical issue as well. So as a result, the consort extension for a cluster randomized trial says, under the principles of the Helsinki Declaration, it's unethical to expose people unnecessarily to the risks of research, because a cluster randomized design increases the complexity of the research and usually requires more participants than an individually randomized design to ensure equivalent statistical power. It is particularly important that the rationale for adopting a cluster design is outlined. So when an individually randomized design is possible, what are good reasons for choosing a cluster randomized design? Well, logistical or administrative reasons are perhaps the most compelling reason. Contamination is another possible reason, although adjusting the sample size of an individually randomized design is another alternative. Pragmatism is often cited as a justification, but cluster randomized designs are not inherently pragmatic, and so pragmatism in isolation isn't a sufficient justification, I think. And finally, avoidance of informed consent is never an acceptable reason. The identification of research participants in cluster randomized trials can be really difficult. Part of the reason is that even though clusters are randomized, the intervention may be delivered at the level of the cluster, the level of the health professional, or at the level of the individual patient. Or the intervention can be delivered at multiple levels in the same trial. Furthermore, data collection may occur at differing levels. While data is commonly collected from individual patients, it may also be collected at the level of health providers and at the level of clusters. So the identification of research participants in cluster trials is, for all these reasons, complicated. Fortunately, the Ottawa Statement provides some pretty helpful guidance. It defines research participant broadly, saying that a participant is an individual whose interests may be affected as a result of study interventions or data collection procedures. And then it cashes this out in terms of several criteria for identifying research participants. So research participants are those to whom the study intervention or control is delivered, those who are interacted with by researchers, and those whose private health information is collected. Research participants can be found at different levels of the trial. Different groups of people may be impacted by differing aspects of the study, and this is a key difference between cluster randomized trials and individually randomized trials. Participants may be impacted by study intervention, by data collection, or both. And this, of course, has downstream implications for benefit-harm analysis and informed consent. Knowledge translation and health services cluster randomized trials commonly impact health providers. And the study intervention in these trials may be delivered directly to health providers, or their data may be collected. In such cases, health providers themselves should be considered research participants. In my experience, this fact is very commonly, and I want to say in the majority of cases, missed by researchers and research ethics committees. So let's move on now from identifying research participants to talk a bit about informed consent, a clearly related issue. As with all randomized controlled trials, there's a presumption that the informed consent of research participants is required. Because of the complexity of cluster randomized trials, differing people in the same trial may be exposed to differing study elements, including enrollment, study interventions, and data collection, as I've just described. So a useful heuristic in cluster trials is to get consent where you can. It's commonly thought that consent issues vary with the unit of randomization, but that's actually not true. Consent issues actually break down with the unit of intervention, not the unit of randomization. So broadly speaking, we see one set of issues for cluster trials, another for professional cluster trials, and yet another for individual cluster trials. So let me just briefly go through each of those. So we'll start with cluster trials. Cluster-level interventions are difficult or impossible to avoid, making refusal of consent practically meaningless. So according to the Ottawa Statement, a waiver of consent is appropriate for cluster-level interventions, provided the intervention poses only minimal risk to participants. Generally, though, informed consent for data collection is still required. Moving on to professional cluster trials, when health professionals are research participants, their informed consent should be obtained unless conditions for a waiver of consent obtain. The patients of those health providers are not necessarily research participants unless the patients themselves are the recipient of the study intervention interacted with by researchers or their health data is collected. And as a result, their consent may not be required. Nonetheless, in many cases, patient consent for data collection is required. Now, finally, the individual cluster trials. Here, the rollout of a drug or vaccine across clusters is sometimes framed as a policy, or it might be a government program. But as they are divisible at the level of the individual, these drugs or vaccines remain individual level interventions. So considerations of informed consent for individual cluster trials are very much similar to individually randomized trials. And that's just because they're all testing the same kinds of interventions. And so if consent would be sought for an intervention in an individually randomized controlled trial, then it should be sought in an equivalent cluster randomized trial. Let's move on now to the final issue of gatekeepers. Who are gatekeepers? Gatekeepers are individuals or bodies who may be called upon to protect the group-based interests that are affected by enrollment in a cluster randomized trial. Now, the Ottawa Statement makes a few recommendations relevant to gatekeepers. The first is an important one. It is that gatekeepers should not provide proxy consent on behalf of individuals in their cluster. When a cluster trial may substantially affect cluster or organizational interests, the gatekeeper's permission to enroll the cluster or organization as a whole should be sought. So who are these gatekeepers? Well, commonly it might include a hospital CEO or a nursing home director or perhaps a school principal. And obtaining permission of gatekeepers is one means of protecting the interests of the organization. Obviously, the decision by a gatekeeper to withdraw a cluster from an ongoing cluster trial may have serious consequences for the scientific validity of the study, and this is best avoided, of course. Further, when cluster trial interventions may substantially affect cluster interests, researchers should seek to protect cluster interests through cluster consultation, to inform the study design, conduct, and reporting. And this very plainly highlights the importance of patient and public involvement in cluster trials to inform the study question and goals, the study design, interpretation of findings, and even the implementation of study results. The Ottawa Statement suggests public fora, community advisory boards, and meetings with opinion leaders to seek this important input. All right, well, what's my brief overview, and this is a picture of the road ahead. What does the road forward hold for us? Well, after almost 12 years, it's time now to update the Ottawa Statement, and I'm very pleased to say that Monica Talliard and myself are leading that initiative, funded by the Canadian Institutes of Health Research. You know, our work plan is going to be to do a number of things over the next couple of years. We are in the process of systematically identifying gaps in the Ottawa Statement. We're beginning a process to update the document to address these gaps. And following on our recent implementation guidance document for hemodialysis settings, we'll be creating 2 new implementation guidance documents for cluster trials. And finally, we'll be creating a forward-looking research agenda. We've assembled a fantastic team for this venture, a true collaboration amongst patient partners, biostatisticians, trialists, ethicists, and so on. And I'm pleased to say that Corey Goldstein and Sean Treweck are part of our team. Thanks very much.